Okay, let's dive straight into this rapid-fire review. Welcome to the Explainer. Today, we are running the clinical gauntlet, hematology and transfusion. We are focusing strictly on high-yield, multiple-choice questions to really test your clinical knowledge. Ready? Let's get started.
Theme 1. Bleeding and platelet disorders.
Which of the following is the cause of increased bleeding tendency in chronic renal failure? A. Liver dysfunction. B. Factor V and VIII deficiency. C. Increased fragility of blood vessels. D. Platelet dysfunction. Or E. None of the above.
The correct answer is D, platelet dysfunction. The primary reason here is that uremic toxins actually impair platelet adhesion and aggregation, which produces a qualitative platelet defect. Here are your exam pearls. Uremia causes platelet dysfunction, not a drop in platelet numbers. That means no thrombocytopenia. Because of this defect, the bleeding time is prolonged. Dialysis improves the function by clearing out those toxins, and you can use DDAVP for a rapid temporary correction. Oh, and the most common clinical manifestation? Mucosal bleeding. A young girl presents with menorrhagia, epistaxis, petechiae, and thrombocytopenia. What is the most likely diagnosis? A. Idiopathic thrombocytopenic purpura, or ITP. B. Hemophilia A. C. Hemophilia B. D. Drug-induced thrombocytopenia, or E. Von Willebrand disease.
And the answer is A. Idiopathic thrombocytopenic purpura. ITP is an autoimmune disorder causing platelet destruction, resulting in a low platelet count combined with mucosal bleeding and petechia. Now for the exam pearls. Isolated thrombocytopenia is the typical lab finding here, meaning your PT and APTT coagulation pathways are perfectly normal. The bone marrow shows increased megakaryocytes, deep tissue bleeding like hemarthrosis is uncommon, and splenomegaly is usually absent on your physical exam.
Theme 2, transfusion medicine, indications and complications. A patient received 8 units of blood and develops jaundice 12 weeks later with elevated liver enzymes. Most likely cause: A. Hepatitis A virus. B. Hepatitis C virus. C. HIV. D. Malaria. Or E. Cytomegalovirus. It's B. Hepatitis C virus. The incubation period of hepatitis C ranges from 2 to 26 weeks, so a presentation with mild hepatitis and jaundice at exactly 12 weeks strongly points to HCV. Your pearls for this one. While HCV is the classic transfusion-transmitted hepatitis, CMV is actually the most common transfusion-transmitted infection overall. Keep in mind, modern blood screening has greatly reduced the risk for all of these. Which hemoglobin level is a clear indication for perioperative red blood cell transfusion? A. 10 grams per deciliter. B. 9 grams per deciliter. C. 11. D. 12. Or E. Less than 6 grams per deciliter. The correct answer is E, less than 6 grams per deciliter. Why? Because tissue oxygen delivery becomes critically compromised at this level. Here are the pearls you need to know. Less than 6 usually indicates a transfusion. Between 6 and 8, it's an individualized decision based on the specific patient. Greater than 8, you generally do not transfuse. Ultimately, clinical status is way more important than the hemoglobin number alone, but restrictive transfusion strategies are widely preferred. A male patient requires immediate emergency blood transfusion. Most appropriate blood group: A, AB positive, B, O positive, C, A positive, D, O negative, E, B positive. The answer is B, O positive. When blood is urgently needed and uncross-matched, O positive is generally used for adult males. O negative is heavily reserved for females of childbearing age to prevent alloimmunization. For the pearls, O is the universal donor for red blood cells. A full cross-match might take up to 45 minutes, but type-specific blood can be available in just 10 to 15 minutes. A 39-year-old man is suspected of having a hemolytic transfusion reaction. Which of the following is appropriate in management? A. Removal of Foley catheter. B. Fluid resuscitation. C. 0.1 m HCl infusion. D. Steroids. E. Fluid and mannitol. The appropriate management is E. Fluid and mannitol. Intravascular hemolysis causes free hemoglobin release, leading to hemoglobinuria and acute kidney injury. Aggressive fluids and mannitol maintain your urine output and prevent that hemoglobin from depositing and causing renal tubular damage. Here are the pearls. The absolute first step is always to stop the transfusion immediately. Then, send samples for a repeat cross-match, aim to maintain a urine output of over 100 milliliters per hour, and alkalinize the urine with sodium bicarbonate to protect the kidneys. Note that steroids have absolutely no established role here. A patient develops a major hemolytic transfusion reaction due to ABO incompatibility. Which step is hazardous? A. Addition of sodium bicarbonate to fluids. B. Infusion of mannitol. C. Immediately stop transfusion. D. Passing Foley catheter. E. Addition of potassium ampules to fluids. The hazardous step is E. Addition of potassium ampules to fluids. Massive hemolysis destroys red blood cells, which releases all their intracellular potassium right into the bloodstream. Adding more potassium on top of that precipitates severe hyperkalemia, which can lead straight to arrhythmias and cardiovascular collapse. The good steps? Stop the transfusion immediately, give aggressive fluids and mannitol, use a Foley to monitor output, and use sodium bicarbonate to alkalinize the urine. Which of the following correctly describes the pathophysiology of a major transfusion reaction? A. Recipient serum reacts with donor cells. B. Recipient cells react against donor serum. C. Recipient cells react against donor cells. D. Recipient serum reacts against donor serum. Or E. None of the above. The correct description is A. Recipient serum reacts with donor cells. In ABO incompatibility, the recipient's pre-existing antibodies in their serum bind to the incoming donor red blood cell antigens. This activates complement and causes intravascular hemolysis. Exam pearls for this. It is most commonly due to a simple clerical error. This complement-mediated hemolysis can rapidly lead to shock, DIC, and acute renal failure. A patient develops fever with chills 30 minutes after blood transfusion. What is the most likely etiology? A. Cold blood. B. Malaria transmission. C. Body's reaction to white blood cells in donated blood. D. Fluid overload. E. Dilution coagulopathy. The answer is C. Body's reaction to white blood cells in donated blood. This describes a febrile non-hemolytic transfusion reaction. It's caused by the recipient's antibodies reacting against donor leukocytes, or the cytokines released from those white blood cells. For the pearls, this is the most common non-hemolytic transfusion reaction. It typically presents with fever, chills, malaise, and headache during or within 24 hours of the transfusion. Even though it's non-hemolytic, you must still stop the transfusion initially just to exclude more serious reactions. You can prevent this from happening by using leukocyte-depleted blood products. During general anesthesia, a transfusion reaction can be recognized as A. Tachycardia, B. Excessive bleeding from wound site and hypotension, C. Fever, D. Seizures, E. Dyspnea. The correct answer is B. Excessive bleeding from wound site and hypotension. Because the patient is under general anesthesia, they cannot report symptoms to you like chills, pain, or anxiety. Therefore, an acute hemolytic transfusion reaction will present silently at first, appearing as unexplained hypotension and diffuse wound oozing from the operative field due to disseminated intravascular coagulation, or DIC. You might also notice hemoglobinuria in the catheter. Recognizing these signs is absolutely critical because this reaction progresses rapidly to shock and renal failure. All right, a final thought to leave you with. What is the single most critical first step the moment you suspect any transfusion reaction? The answer, every single time, is to stop the transfusion immediately. Thank you for joining this explainer, and I'll catch you next time.